Alright, hi, my name is Mike. I'm going to be giving a talk today on pleural effusions. Basically some stuff that you could help you on the wards, and also a little bit of pathophysiology of effusions and a little bit of anatomy of effusions as well, to kind of give you guys a little bit of an idea of what to think conceptually, just sort of organize things conceptually. So before I get started, I'd like to talk about a few terms. Whenever you are evaluating pleural fluid, what are the two big terms that you would consider, two big encompassing categories in which pleural fluid can fall into?
Transudate and exudate.
And the physiology of transudate and exudates is something that I want to talk about before I launch into a little bit of anatomy. I'd like to, and the physiology of transudates and exudates are the same as basically it's fluid dynamics, basically fluid stuff. So here we have a vessel. This represents the vasculature, and out here we have like the interstitium. What are the forces that maintain the fluid balance between the vessel and the interstitium?
Osmotic and hydrostatic pressure.
Okay, so we've got hydrostatic pressure forcing hydrostatic pressure going outwards, and we have osmotic pressure keeping fluid within the interstitial space, right? So now is a good time to probably talk a little bit about what pleural fluid is and a little bit about the anatomy. So what I'm drawing right now is the pleura. This is the chest wall. I'm going to draw a big vessel in the chest wall. This is the lung. I'm going to get a better pen. This is the lung. So, here we got one vessel. This is a vessel in the chest wall. Here we have another vessel. I'll draw some blood cells just so you can kind of see what's going on here. And this is the pleural. This is the pleura. As you breathe in, these sort of membranes kind of shift up against each other, like one against each other. And the pleural fluid is sort of a lubricant for the two of them. So where does the pleural fluid come from? In actuality, it comes from the increased hydrostatic pressure pulling fluid out from the capillaries of the chest wall. In other words, when you breathe in, you create negative pressure, right? And so if you're breathing in and creating negative pressure, that's going to increase the hydrostatic pressure. That's going to put fluid just sort of into the intrapleural space. And then from the interpleural space, it's going to go one of two places. The negative pressure is going to have it move further in. Maybe red will do better. All right, there we go. So, so this is a vessel. So it'll move further in and get taken up by the capillaries of the lung, or there's also these things called lymphatic stroma. Basically, they're microscopic one-way valves that are involved in taking up. When you breathe in, they kind of open up. And you take up cellular debris, and it also takes up fluid through there. So that's another way that it goes. So now going back to our diagram of osmotic versus hydrostatic pressure here. A transudate is basically fluid extravasating through the vessels into the interstitium, or in this case into the pleural fluid, through one of two things: a decrease in osmotic force holding it in, or an increase of the hydrostatic force pushing it out. So name a type of name something that could cause a pleural effusion.
Heart failure.
Heart failure. Okay, excellent. So first one will be heart failure. Heart failure. Does heart failure play any role on changing the
increased hydrostatic pressure
Yeah, absolutely. So we see here, these are capillaries in the lung, or we can just make this vessels in the lung. So if you have heart failure, your left atrium is backed up, and you have increased pressure in your pulmonary veins and vasculature, and you have more of a pressure moving out, so fluid moves into the interstitium, and then further on past that moves into here. So if you have a patient who's got obvious signs of heart failure, an S3 gallop, swollen legs, you can kind of guess from there if what kind of effusion this is. Do you think a heart failure thing would be a bilateral pleural effusion or it's a unilateral? Would it be both sides? Would you get heart failure? Would you get both sides or one side?
More likely both.
Yeah, absolutely. Like 80 to 85% are on both sides. And so that leads us to the treatment of heart failure or increased hydrostatic pressure related pleural effusion. You can diurese and see how it works. And if it doesn't work, then maybe you might consider tapping it. It depends on how big the effusion is, but diuresis would hopefully take care of it because the person is fluid overloaded. Name another type of pleural effusion.
Related to infection.
Okay, infection. Now, exudates happen. Transudates is going to be basically molecules that are permeable to the membrane, ions, or not permeable to the membrane, but permeable to the vessels, which is ions and water. In this case, there's actually some albumin and bicarbonate also in here. But in some cases, capillaries and vessels in general become increasingly permeable because of localized inflammation. So if you have an infection of the lung, you get increased capillary permeability that causes fluid to freely escape. Basically, you lose your osmotic pressure because there's no more osmotic gradient. Things are being lost, and so in the case of that case, it'll be an exudate. It's not a transudate because it's got it's got intravascular proteins, it's got cells, it's got a whole bunch of junk in it. So that would be infection. Would you expect infection to be a unilateral or bilateral pleural effusion?
Unilateral.
Yeah, most of the time it is. So if you get a unilateral situation, you go straight to the thoracentesis. You analyze it to see if it's a transudate or an exudate. You go from there. If you end up with an exudate, you can other causes of exudates could be any other cause of localized inflammation, and that can include malignancy. Okay. So I'll put malignancy as a possibility here, but malignancy can cause both.
Is there a formal definition of transudate versus exudate?
Yes, there is, and that brings me to the criteria. Are you familiar with Light's criteria?
I've heard of it before.
Off the top of your head? Okay. So Light's criteria is basically if you have one of the following. Serum protein. Oops, that's wrong, I'm sorry. Pleural over so the ratio between pleural protein and serum protein greater than 0.5, or the ratio of pleural fluid LDH to serum LDH greater than 0.6. Also, the pleural fluid level is greater than 2/3 the upper limit of normal. It's also any of those three meets Light's criteria. You're dealing with an exudate. Exudate certainly requires more evaluation afterwards because they're so things like sort of a cell count, glucose level, cytologic analysis could kind of lead you more down to understanding why, in particular, the inflammation is happening, and cytology, of course. Also, if you're concerned that it might be a cancer. Where's another instance that if we go back to this right here, our blood vessel right here, another cause could be another way that we can get a decrease of osmotic pressure holding everything in could be through the loss of intravascular proteins. Either you're not making enough of them, so we can also put liver failure here as a transudate, or you're losing proteins, possibly in the urine, so I'll just say that's nephrosis. So those are two other reasons why you're going to have a transudate effusion. Which time?
10:30.
Okay, cool. That's fine.
Do you want, that's fine?
That's